aid, they'll provide social worker that provides support and things like that. So any questions on this? Does this look familiar for folks who have thought about this or planned for it? Okay, so let's look at that other handout. Okay, so one thing that often comes up on this one that I wrote first is pain and how are we going to manage the person's pain. This is a worry that a lot of people have, in addition to worrying that they're dying, what kind of pain will I experience? So back to my mom. So this says not everyone who's dying experiences pain. So my mom was never on any pain medications, even to the end of her life. She was very quietly kind of fell into a deep sleep. Sometimes she would open her eyes, but beyond that, with the hospice assessment, there was no evidence that she was experiencing any pain. We could rub down her legs, we could grab her shoulder, we could kiss her, and there was no recoil, so there was no indication she was in any pain. My dad, on the other hand, late the last few days of his life was experiencing some jolts of pain. He could not talk or really wasn't waking up, but you could see him kind of jolt in his sleep, so they gave him some oral morphine for that. My father-in-law the same way, very late in his life, even though he could wake up periodically, he would say, you know, pain or help for pain, and so they would provide him some oral morphine. My uncle was in so much pain that they, at the hospice house, they were actually, I believe, giving him injectable morphine just to keep him unconscious and quiet so he could sleep until he got. So this is a big issue that comes up a lot, how to manage the pain. I think hospice care has gotten really good at this aspect of what they do in managing pain so people do not suffer going into that end period of their life. Some people get so much pain relief that they're almost giddy in those last few days of their life that they're awake, because the morphine and other things they can do to intervene can really help manage the pain. So right there, when we talk about morphine and other painkillers, successfully reducing pain, addressing concerns about breathing can provide needed comfort to someone who's close to dying. Sometimes people can experience confusion, drowsiness, some hallucinations. In my dad's experience, my father-in-law's experience the same way. It was just pure comfort that they got end of life for these interventions. So anyone want to share if they've had a family member go through the pain management end of life? Okay. Breathing problems, that's another thing that comes up. It's called dyspnea. To help ease breathing, there's different positionings you can do for the bed. Sometimes they'll do this as part of the hospice interventions that they're doing. Sometimes there is an abnormal breathing pattern. They say this is known as Shine-Stokes breathing. It can alternate between deep, heavy breaths and shallow or even no breaths. This can be very frightening to people who are observing this. The other thing that you'll see oftentimes is that the hospice team might recommend that the person not have any artificial nutrition or artificial hydration. And this is why it's important to have those legal documents in place to make sure those things are clear. So one thing that came up, like with my mom, she was asleep and with her mouth open and her lips would dry out. So one thing they said, well, yeah, you can moisten her lips if you want to, but we're not going to be adding hydration to her drip. She wasn't going to get any hydration. And this was kind of upsetting to my family members because they were saying, well, she's going to dry out or she'll starve to death. It's going to be horrible. But basically the body at that point isn't processing water or food. It's basically like pumping a balloon up. Well, the balloon will get bigger and bigger, but nothing good's going to come of that, right? It's just going to pop at the end. So it's the same way. You can pump a dying body full of fluids and food, but it's not going to change the trajectory of the illness, and nor is it going to provide any comfort to the person. The other thing that came up with hospice care, like with my dad, the last couple of days, he started to run a fever, and the skilled nursing facility team was like, okay, this is indicative of an infection, so we should probably start a trial with antibiotics. The hospice care team was like, no, late in life, at the last few days or hours, typically a person's body will heat up because blood flow and everything is pulled from extremities to the torso and brain to keep those organs alive. So that's why late in life you might see a person's fingers turn blue or their feet get very cold, because the body's reacting to the dying process and pulling blood and energy to the torso and brain, and sometimes a person will run a fever. So again, my view was like, oh yeah, sure, start them on the antibiotics. The hospice team was like, no, you're not doing anything by that. There's no infection going on. It's just the dying process. So these are examples of what seems like common sense in terms of treatment that in hospice takes a different structure around it. Okay, any questions on that? Okay. Skin irritation, skin problems. A person can feel uncomfortable when they're dying with skin irritation. Like I said, with my mom's lips drying out, things like that, dryness. There's a lot of recommendations in here about how you can handle that. Lip balms, petroleum jelly, things like that. There's digestive problems that can develop with a person that can't swallow. This is a typical thing that happens end of life. Losing appetite. Sometimes you can use some very mild foods that are pureed and things like that for a person. But like I mentioned with my mom there, don't force a dying person to eat. Losing one's appetite is a common and normal part of dying. Going without food and water is generally not painful. It can actually add to a dying person's discomfort. So, and that's what I experienced with my family members. Temperature sensitivity is another one. A person might feel too hot, too cold. Sometimes they can express that. Sometimes it's just kind of an assessment of how their body's reacting to different things, whether you cover a person up or whether you cool them down. And then for people that are still awake and able to express how they're feeling, fatigue is what allows people to express in that end of life situation, that they're just exceedingly tired and feeling like they have no energy at all. Of course, they're managing mental health and emotional needs. That's a big one, of course. So this is where typically a person will want some reassurance about their situation, that there's support for them. This is often where faith-based kind of interventions happen, like I mentioned, with a minister or a spiritual guide or a counselor of some kind. With my mom, and both my mom and my dad, it was just, we would just whisper in their ears, tell them how much we love them, that we're here for them, that we hope they have a good journey, that they're going to see long lost relatives. With my dad, he loved music from the southern part of Italy called Calabria, so I found a YouTube channel that played the Calabrian music. I would play that for him when I visit him. So it's really individual based on the family member, what's going to provide the most spiritual comfort and emotional support. And then, like I mentioned with my mom, we actually did the Catholic intervention with what used to be known as the last rites for her. Then on that next to last page, questions about things like, should there always be someone in the room with a dying person? Some families have vigils where someone's there all the time during those late in life situations. I'd have to say that we never really got really good at that, other than with my father-in-law, that we just happened to be there like 2 a.m. when he passed away. My dad, I think I left the room Sunday night around midnight, and then I think he passed a couple of hours later. They called me. My mom, she actually passed away, I think, on Christmas morning. So everybody was at my dad's house having Christmas morning breakfast, and then they got the call that she had passed away. So this is something I think that all families aspire to, that everybody's there. But again, it's more art than science. You just don't know exactly when it might happen. I would say that on hospice, once they stopped feeding and water to my mom, the hospice care nurse said, okay, no more than 7 days, she'll pass away. So we were there like every day into that 7th day, which was Christmas Eve, and then she died the 8th day, which would have been Christmas morning. So even then, like, you're there as much as you possibly could be, but there's family obligations, there's work obligations and things that come up as well. So so this is a nice document I found that really kind of talks about all the things that possibly can happen, all the support that a family might want to think about, all the reasons that certain decisions are made with hospice. Last paragraph there, I think this is very powerful. In the end, consider that there may be no quote unquote perfect death. So just do the best you can for your loved one. The deep pain of losing someone close to you may be softened a little bit, knowing that when you were needed, you did what you could. And I think that's the most we can ask for when we're doing this planning, because it does get very complicated. And that's why when we talk about the legal documents, we'll talk about how important it is for these end of life decisions to already have been established by that person. We already had these for my mom and dad and my uncle, these end of life wishes in terms of, do you want feeding? Do you want hydration? What kind of music do you want playing? Do you want to have the priest come in and provide the last rites to you, things like that? Having it written down really does make a big difference in terms of allowing the family to follow instructions they've already been given by the person who's in the dying situation. So that was a lot of information. I apologize, but any questions or comments on that? Okay, so the talk today is titled End of Life, Palliative, and Hospice Care. So the two often get confused, and so we're going to talk a little bit about what the different definitions mean. Palliative care is something that's really been developed over the last several years, hospice care as well. And these, in my view, are really positive developments for the medical establishment to really move in this direction in terms of how they're treating people with chronic illnesses or terminal illnesses, okay? So what is palliative care and hospice care? Palliative care aims to improve overall quality of life for a person suffering from a serious illness such as heart failure, COPD, dementia, or cancer. The person still receives treatment for their underlying condition. So this is what confuses a lot of people. The person is still receiving treatment for their condition. So this person could be having tremendous bone pain from cancer treatments, or they could be having COPD, shortness of breath on oxygen, and laboring with their breathing and things like that. They're still being treated for the underlying condition. So this is one thing that makes palliative care different than hospice care. Palliative team supports the person in other ways, including treating fatigue, weakness that can develop, for example, from chemotherapy, or addressing anxiety and depression a person might experience resulting from their illness. Palliative care is appropriate for anyone with a serious illness, whether it's chronic, curable, or life-threatening. So again, this kind of sets it apart from hospice care. There's no terminal diagnosis that has to happen. There's no abandonment of treatment in order to move into like a hospice situation. Plus the regular treatment team and doctors continue to treat the person. So it's all about how do we manage the discomfort this person's experiencing with the extraordinary measures being taken to treat this person with these chronic illnesses or disabling injuries, whatever the case might be. So this is often misunderstood because people wonder, well, who's ordering the palliative care? Well, it's really kind of a treatment modality that the existing treatment team already sets up. So my dad, for example, was actually on palliative care during the last few days of his life because his illness came on very suddenly. Prior to that point, he had been pretty functional. So right away, the doctor at the skilled nursing facility, when I talked with them, ordered the palliative care so they could administer like the oral medications to treat his pain and things like that. Our view was kind of like, we will see what happens over the next few days and then consider hospice care, because he had been on hospice care and came off it. Well, this was like on a Tuesday, we started the palliative care measures, and then he died that following Monday morning. So had we gone into that next week, we probably would have asked for a hospice care order, just didn't develop that way. Any questions on that, on how that works in palliative care? Hospice care, on the other hand, provides comfort, care, and family support for someone with a diagnosed terminal illness considered to be having 6 months or less to live. Key difference then from palliative is that the person does not receive curative treatment for their terminal condition anymore. So, for example, my uncle with leukemia, when he developed that intestinal blockage, we had met with the doctor like a week before when we got the really bad news about his leukemia, his cancer doctor. And the doctor said, the labs have gone haywire, everything's back worse than it was when we started, because he had like a 3-month period where he seemed like he was getting better. There's nothing more we can do. He said there's some research studies going on at UW Seattle you might want to look into, but he said, I'm not going to be ordering any more treatment for you because I am now listing you as being terminally ill. So at that point then, there was no more treatment happening. When he got the intestinal blockage, he had this incredible pain, of course. He called me, and so I took him to the emergency room. And the emergency room doctor said, your uncle's got this intestinal blockage. He is terminally ill. So you as power of attorney can decide, we can operate to clear this blockage, but he may die during the surgery. At best, he survives the surgery and he's probably going to be dead in a few weeks. And so that's when I called Franciscan Hospice and found out they had a bed available. We transferred him. Again, like I said, the doctor said he might have 2-3 days and he died the next morning. So that's an example where there was no more treatment for him happening because I had decided that he just needed comfort care, and the doctor basically decided that going forward with treatment wasn't going to have any impact any longer. However, the person still gets medical care to help relieve symptoms related to the disease, as well as other types of support such as counseling, help with medical equipment, and grief support. So yeah, my uncle went into the hospice care facility with full pain management, and he died unconscious with pain management in the hospice care facility. So hospice care has very specific eligibility. Person must be diagnosed, 6 months or less to live, must no longer pursue curative care. The person may choose hospice because they are no longer receiving benefit from treatment, or they simply do not want to be treated any longer. Yes?
So our mother has congestive heart failure.
Okay.
So to go on hospice, would she have to quit taking, she's on a very heavy duty heart medicine, amiodarone.
Okay.
Would she have to go off of that then?
Most likely that would be something for the hospice care doctor to decide whether having the medication in place is adding to her comfort care. So I've seen those conditions happen as well.
Okay.
So if that would prevent her from maybe experiencing some additional pain because of the congestive heart failure, it would really be up to the hospice care doctor to decide on that. So this is a great question though, because this is what comes up. Because for example, with my other uncle who died, he was on dialysis for a couple of years. My dad used to take him. And then, he was getting weaker and weaker, thinner and thinner. And his wife, unfortunately, had already died. His one adult daughter had already died from cancer. And so at some point he told my dad, I don't want to do this anymore. So he basically chose to go on hospice at that point. He said, I'm done with the treatment. So no more dialysis was scheduled. But we still did keep him comfortable, maintain medications and things like that were keeping him comfortable. So it would be a good question for the doctor, and I might be answering you wrong, but it's be a good question for the doctor.
Okay, thanks.
Yeah. So like I said, sometimes it's a decision the family makes, like in my parents' situation, I was deciding for them. In my in-laws, my wife was deciding for them. Other times with that other uncle, he basically said, I'm done here, I'm not gonna continue treatment. I think he lived like 2 weeks after that and then passed away on hospice. Okay. Who provides the care and when? So palliative care is provided by the existing team that's treating that person, and may include the doctor, may include a nurse, a pharmacist, social worker, dietitian, chaplain, volunteers. All of these people that are probably already supporting the person, like if they're in cancer treatment or something, are going to continue to be involved with the person on palliative care. Hospice care, on the other hand, is provided by a team that might include the hospice medical director, nurse case manager, social worker, bereavement counselor, home health aide, hospice volunteers. So these are probably all going to be brand new people into that terminally ill person's life. Unlike the palliative care where they're the existing team already working with them for the most part. So it's brand new people that come in. So one thing that worries people on hospice is that, well, what do I do if there's an emergency? So this is why we'll talk about the legal documents, because when a person's on hospice care, the orders come from the hospice team, 24 hours a day, 7 days a week. So the care facility where my dad was and my mom, their view is, of course, we need to keep this person alive, right? Because that's their job as a skilled nursing facility, medical building. The hospice care team is, no, we want this person to peacefully die, okay? So this is where you often, as a family member, can sometimes feel some cross purposes there in a care facility, because with the proper legal documents, that means there's no calls to 911 for treating my mom. The calls go to hospice care to manage the pain or whatever discomfort's happening. So sometimes you can find that friction that occurs with the two teams through the way.
Would that be the same as like, at this point, our mom is still at home,
Okay,
so would that be, I mean, and our goal is to try to keep her at home if we can,
yes.
so.
So again, this is my judgmental view. Other people can view differently. In my judgmental view, you're more likely to keep her home on hospice than you are trying to treat her for whatever condition she's having. Because typically, without the hospice, the treatment will continue and continue, meaning you're probably at some point gonna be in an emergency room with her again, and probably at some point she's gonna be in the hospital again. People die in hospitals, so this is where the family really has to have the documents in place and hopefully have some guidance from her. If that's a value for her, writing that into her advanced directive or living will, if that's the situation she wants to be in. Because then, with those documents, with the pulse form we'll talk about, then you're not trying to keep her alive at home. You're hoping she'll peacefully pass at home. Does that make sense to folks? It's kind of a distinction, but yes.
I'm unclear on the palliative, how that's diagnosed. In other words, my husband has severe back pain
Okay,
and has a pain doctor that he has to see if he's on opiate orders. And then his PCP that Medicare requires. But they don't come to the house. I mean, can
No.
any doctor recommend palliative?
yeah, absolutely, yeah. Any doctor can kind of consider the situation and decide, with conversation with the patient and hopefully the family, what the next step is for comfort while that person is going through the treatment for whatever situation they're in. So it's part of the treatment team, so I don't know how long the pain doctor's been involved. Is that a new development or is that something that's?
A little over a year.
Okay, so they may have been moving that direction of palliative care for pain management. So you might want to ask them, is that kind of the model that he's already being treated under as palliative care? It's not so cut and dried as hospice care. Sometimes they'll call it comfort
Yeah.
care. There might be other terms they use for it.
Because none of those other people are involved in
Okay, so again,
it. It's me.
I was using the example of like a cancer patient where there might be a volunteer that drives them to get his cancer treatment. There might be someone in a support group they're involved in. So I was trying to kind of look at it in terms of what are some surround services that might already be happening with the person. So the fact that he's got this pain management doctor prescribing these opiates for him makes me think that it's already kind of in a palliative care model. So you might want to ask what additional supports might be available for you to kind of understand better how to manage those things under the palliative care model, like a social worker talking with you or somebody like that. So does that kind of answer the question?
Yeah, I guess so. I guess I didn't realize just any doctor could.
Yeah.
Because his PCP, I can't see doing that.
Yeah.
Because he's just leaving, so.
Okay, yeah. Sometimes there is a bit of education that goes on, unfortunately, where the family really has to start throwing ideas down on the table for the doctor to kind of understand what you're experiencing in managing the day-to-day life of your
Because
husband.
he's not gonna stop these it's
No,
never
no.
gonna get better.
Absolutely, yeah, so that's why the palliative, maybe there's some additional elements to that that you can add that would provide some additional support for you to make sure he's comfortable and doing well with the treatment.
Right.
So yeah, that would be a dialogue you might wanna have, maybe there's a missing piece there.
The pharmacist is somewhat involved.
Yeah,
Because it's so controlling.
exactly, yeah.
Fentanyl patches.
Yeah, it's very difficult on those to not do it without the pharmacist being very involved.
So as long as they're on the care that she's talking about, then it is a palliative care situation. If they went to hospice, then they would take away.
Whatever the treatment is for the terminal condition, that would end. So like with my other uncle, he ended his dialysis. Now, if he had said, I've taken another thought about it, I guess I should continue the dialysis, then he would have been off hospice again.
But in her case with the opioids.
Yeah, he's not terminal.
So he's got a chronic condition.
Oh, yeah.
It's a chronic condition that's not likely to go away.
Right.
And is causing him a great deal of discomfort. So that's where the palliative care is happening.
Because if hospice was involved, they might take away the.
Yeah, and that would have been based upon the terminal diagnosis. So a palliative care person doesn't need to have a terminal diagnosis. They just have to be in a situation where the illness and the treatment for the illness is causing a lot of.
I'm so sorry to interrupt, but you might need to click something
Oh,
like
no.
within a second.
Oh, no.
Sorry.
Thank you.
I think your second was up.
I know, unfortunately,
Sorry, I'm back.
no.
Okay.
So these are really great questions you guys are asking, because it does add a lot of confusion when people think, okay, they're both managing pain. What are the diagnoses involved and what has to happen? And again, these situations sound pretty clear cut, what you're describing with your husband, yeah. With my uncle, it was pretty clear cut that without the dialysis, he was going to die. I mean, there was just no doubt about it, because his body was gonna get toxic.
Right.
And so once he told the doctor that decision, the order was written, okay, hospice care. Prior to that point, it was comfort care, because the dialysis is uncomfortable, it's fatiguing. But it's not terminal to be end-stage renal disease. You could be in stage 4 renal disease. People live on dialysis for a long time. But once you decide I'm done with it, then you're terminally ill at that point.
So this would be probably a good case for some of the resources you've been talking about with the
Yes.
county, like say, the bedside, you know, it's extremely difficult for a
Yes.
walk.
Exactly,
Yeah.
yeah, so that's why you might want to talk to our folks about family caregiver support, where we know there's some interventions we can provide there that might make things more comfortable at home for you as the caregiver and for him as the client getting the care. And we do some caregiver counseling with that, so yeah, definitely we do that in my own.
Now we can watch a movie.
Sorry, this thing is brand new, I have no idea.
That's okay, I got an extra handout here.
Okay.
Oh, there it is.
There's that little one. Okay.
Yay.
Okay. Okay. Most home health agencies offer hospice care. Many of them are called home health in a hospice. And so home health is what's typically ordered when someone's had an injury or illness and they've been hospitalized, not necessarily, and they need some rehabilitation follow-up at home. So it could be physical therapy at home, occupational therapy, respiratory therapy. My dad and mom both fell a couple of times where they had physical therapy, occupational therapy, respiratory therapy, and a social worker come into the home, do rehabilitation exercise, breathing exercises. These agencies typically also do offer hospice care that can happen in the home, like someone asked about, it can happen in the home, where instead of doing home health, they're doing hospice care. Most treatment providers for chronic life-threatening conditions can offer palliative care. So like your husband's example, ma'am, any doctor that's a cancer treatment provider or a primary care doctor that's having clients in cancer treatment, whatever the case might be, they can offer the palliative care. It's comfort care. Physicians are required to start either palliative or hospice care. So again, you're going back to the doctor having to guide a little bit on this.
So what would he be ordering for the palliative? That's what I.
It'd probably be like the intervention management doctor. So I don't know how that evolved. Did that order happen to get that pain management doctor?
Oh, no, I found one.
Okay,
His
so,
PCP was totally against opioids.
okay, so this is a great question that I don't have a good answer
Yeah,
to,
well,
where,
I mean,
you know,
if he would be the only doctor now, they could order
okay.
it, the same doctor.
Yeah. So you found it, so that's great, because this is part of why we're here. We're wanting people to know these treatment modalities are available. So having that pain doctor, I think, is probably the one now who you would consider conducting the palliative care.
But in ordering that, she would be available, she would have other resources available to her if he actually wrote on the thing, how does it care, would she have other resources?
Yeah, because typically, as part of what the pain management group does, or the underlying condition, he's being treated for an underlying condition as well, right, your husband?
Other than Parkinson's
Okay.
and diabetes, I mean, he's got those things, but not,
Okay. So
yeah.
yeah, typically then they may be able to do a social work assessment in your home. They might be able to provide some other care management in the home that's helpful for you. Doesn't sound like there's much of that going on, so, okay. I would really, okay, I really encourage you, call and talk to our family caregiving team. I think that would really be helpful, because they're gonna guide you better than I can.
Get that palliative care.
Yeah,
Okay.
really good question, so, honestly, oops. Okay, Medicare and palliative and hospice care. So like we've been saying, continuing on that theme, Medicare B, most commercial insurance and for employers, TRICARE, Veterans Health Coverage, Medicaid, all pay for palliative care depending upon the treatment. Medicare, this kind of goes back to what we were talking about where it gets a little foggy. Medicare generally does not separate palliative care from the remainder of the person's covered services. So a palliative care provider will be paid like any other doctor. So I think this is some of the confusion people are experiencing because it's a modality rather than an order necessarily. So it's kind of understanding that it's comfort care and how that should happen. It's not nearly as definitive as hospice care is. So that's kind of where it feels murky, and it is murky. Medicare Part A, most commercial insurance, TRICARE, Veterans Health Coverage, and Medicaid pay for hospice care. More details on the following slide. So Medicare hospice information, this is the new Medicare, most of you who are on Medicare should have already got it. It's basically on page 28 where it talks about Part A covered services, including hospice care and what all that means. And we'll talk a little bit more about that. But again, this is something confusing because normally Part A covers anything happening in a hospital or a skilled nursing facility. In this case, Part A covers something that can happen in your home, which could be hospice care.
Matt, I think it might be helpful to, like, I know Kaiser, for example, if somebody's on a Kaiser Medicare Advantage plan,
Okay.
Kaiser has their own palliative care team.
Yeah,
And so if somebody is under Kaiser, then they most likely get a consult from within their own sort of insurance group for a palliative care consult and
exactly.
then also hospice.
yeah, so it's a great question, kind of leading into where we're headed. Yes, so does Medicare pay for palliative and hospice care? These are the basic benefit for Medicare hospice care. Even if you have a Medicare Advantage plan, it's original Medicare that the providers bill for hospice care, not palliative care, for hospice care. So I had a gentleman who called me in a panic because he had added a United Healthcare Advantage plan the prior year. Now he was terminally ill. So he called me and said, and there's no client of mine, he said, Matt, what's going on? I called my Advantage plan and they said I don't have a hospice care benefit. Well, you don't, but you don't lose it. It just goes back to your original Medicare. So first of all, do people understand what I mean by an Advantage plan? So it's like Jan was describing. Kaiser's a good example. Kaiser's formerly Group Health, very tightly controlled service network. You can join an Advantage plan with your Medicare, that's a Kaiser Advantage plan, which means you're going to circulate among doctors and service providers within the Kaiser network. If you go on hospice though, you're back to original Medicare. So Kaiser would probably recommend their own home health and hospice service to provide that, but conceivably you could get it from any home health agency that doesn't have to be Kaiser affiliated. So this is where it gets confusing because palliative care is something that could happen in the Advantage plan world because it's not as separately defined. Hospice, however, is original Medicare again. So that's where we are at. It's very well covered though. You typically have a co-payment of up to $5 for each prescription, outpatient drugs for pain and symptom management, no more than $5. In the rare case a hospice benefit doesn't cover your drug, they may be able to bill that back to Part D. So normally we're accustomed to thinking outpatient prescriptions are part of your D plan benefit. In the hospice world, it's part of the hospice Part A benefit, okay? The hospice provider will be able to inform you of any drugs or services that aren't covered and whether you'd be required to pay for them. Most cases you wouldn't, it would just bill out differently. You may pay 5% of the Medicare approved amount for inpatient respite care. Your copay cannot exceed the hospital inpatient deductible. Original Medicare will still pay for covered benefits for any health problems, not part of your terminal illness and related conditions. But this is unusual because once you choose hospice care, your hospice benefit will usually cover all that you need. So then it's all being part of that hospice benefit package, even if you're seeing doctors treating you for other things, and the terminal condition's no longer being treated anymore. You may have to pay for room and board if you live in a facility like a nursing home and choose to get hospice care. So my mom, in that last week of her life, was on hospice care in a skilled nursing facility. She had stayed there after her Medicare coverage ended. We were paying privately for her to be there. So we still had to pay privately for her to be there, but the hospice services, the nurse that came in, the social worker, the minister, all that, that was covered as part of the hospice benefit. She already was getting baths and things, so we didn't need a bath aide to come in. Now, if she had been at home, it would have been a different story. There wouldn't have been any room and board situation, but people are under the impression that you could go into a care facility like an assisted living. Once you go on hospice care, you're not paying for the assisted living. You still are. You're just getting a specific team that comes in to treat your situation in hospice. Does that make sense to everybody?
Matt, quick question.
Yes.
So if somebody's on hospice, because we've had this happen a number of times.
Yeah.
And say they fall and hit their head, you know, 911 will be activated. And oftentimes people will want to go to the hospital to have that evaluated. It's not what they're on hospice for. So who pays for that hospital visit? Is that still Medicare under the hospice benefit?
And yes, and it could potentially be problematic because they may say that the person should have been treated and handled at home and not gone into the hospital. So it can be really dicey in those situations, because normally if something life-threatening develops on a hospice care patient, it should not be sent to an emergency room. That's my understanding of how it works.
So then what do you do? So they fell, they hit their head, you know, your immediate reaction is to call 911.
Yeah,
So is there another number to call? Is there a hospital?
typically, yeah, there would be a hospice number.
Okay, so you would be doing something. It's not like you're going, I'm letting this person lay on the floor.
Exactly, yeah, you would have a hospice number to call, and that would probably be something that they would talk with you about in those situations, what's gonna happen when you call them in terms of what they're gonna guide you on what to do.
And we've had that happen.
Okay.
So like I've been at, you know, the lead paramedic on a call where somebody was on hospice, they fell, they hit their head. And I had the conversation at scene with the hospice nurse. Okay, here's the situation, here's what I'm finding. What would you like us to do? Or how would you like to advise the family what to do? And so it's been really sort of
Okay,
a
great.
team conversation. Doesn't always happen,
Okay.
you know, I'm not the typical paramedic,
Yeah, no, I
but
gotcha.
you know, that can happen. And as the family, I think it's important for you to know that you can ask for that conversation to happen. Yes, you may have that instinct, call 911, but your next call maybe should be to the hospice team. I called 911, what should I do? You know, type of thing. Hospice should really be guiding those decisions.
And you kind of want them to, and I may be a selfish opinion here, but you don't want to be the one to go, I just let mom die. You know, she's on the floor, right?
It's like,
Hospice is doing this and hospice is doing that, and
right,
it's kind of relieves you of some of the,
yes.
I'm not letting her.
So this is a great discussion. I really appreciate that, Jen, because this gives me an insight outside of my awareness. So, and we'll talk about this on this particular slide. So it's a wonderful lead, and I really do appreciate that. So only your hospice doctor, regular doctor, can certify you're terminally ill. We talked about that life expectancy. After 6 months on hospice care, you can continue to get hospice care as long as the medical director or hospice doctor recertifies with a face-to-face visit that you're still terminally ill. So it's not a hard and fast rule, oh, you've gone 6 months and then you're off it again. It could be 6 months and they could order it for another 6 months. Somewhere within that other 6 months, they may decide you're not terminally ill anymore. Again, it's on the judgment of the doctor and the family kind of reporting what they're seeing as well. Medicare will not cover any of these once your hospice benefits start. So this is kind of relevant to what Jen was talking about and the question you had there. They will not cover, we're gonna use Medicare as the guide because Medicare kind of sets the rules for all the other coverages. Will not cover treatment intended to cure your terminal illness and or related conditions. Talk with your doctor if you're thinking about getting treatment to cure your illness. As a hospice patient, you always have the right to stop hospice care at any time. So like I mentioned with my other uncle with the dialysis, if he had decided after a week, oh my gosh, I made a mistake, hospice would have ended, he goes back on dialysis. They will not cover prescription drugs to cure your illness rather than for symptom control or pain relief. So in your question, this is kind of that foggy area. Maybe he would say it's going to manage her comfort better to keep her on that. So maybe he would say she would stay on that. On the other hand, he might say she wouldn't, I don't know, so. Care from any hospice provider that wasn't set up by the hospice medical team, you must get hospice care from the provider you chose. All care that you get for your terminal illness must be given by or arranged by the hospice team. You can't get the same type of care from a different hospice unless you change providers. However, you still see your regular doctor or nurse practitioner if you've chosen him or her to be the attending medical professional who helps supervise your hospice care. So I've seen this go different ways. I think I've seen it where the doctor does remain involved and the hospice care services still remain involved. I've seen where it just becomes hospice care at that point with a hospice care doctor. I've seen it go different ways, so I don't want to be too definitive and stuff I'm telling you because this is where questions might come up. Medicare does not cover room and board if you get hospice care in your home or if you live in a nursing home, like I talked about with my dad. If they determine you need short-term inpatient or respite care services that they arrange from the hospice team, they will cover that stay. Care you get as a hospital outpatient, like in an emergency room, typically not paid for. Care you get as a hospital inpatient or ambulance transportation, unless it's either arranged by the hospice team or is unrelated to your terminal illness and related conditions. So this is probably some of the conversations you've had, Ken. What is this looking like? And that fall you talked about that would happen. What is that looking like? So it sounds like from this provision here, that hospice call has to be made. You have to have the hospice team aware of what's happened before other decisions are made. So, and oftentimes it sounds like you guys get that case and you're talking to the hospice team.
Yeah, and we've had it happen where somebody will actually revoke hospice to go into the
Oh, well,
emergency
see, there you
department.
go.
Maybe be admitted as an inpatient,
Okay.
or whatever they had for insurance before then would cover it, and then they go back on
Oh,
hospice
see,
when
that's
they're,
something I didn't know either.
when
so-
they're released back.
Okay,
And is that because, as it says here, it's unrelated to the hospice? So then you could revoke it because you're not using the hospice, if it's another issue that's happening.
Right.
so there's kind of an out here the way it's described, because it basically is saying from up above, Medicare won't cover any of these once hospice benefit starts. Care you get as a hospital outpatient, like in an emergency room, care you get in the hospital, ambulance transportation, unless it's either arranged by your hospice team or is unrelated to your terminal illness related condition. So I think what my first answer to you about that fall, based upon this, is probably wrong, in that you would still make sure hospice is aware, but it sounds like they probably would say treatment's okay to go forward.
Because it's unrelated.
Exactly. So I apologize, I think I got.
Although, you know what, I think you're gonna argue some point in there, well, she fell and hit her head because of the congestion. You know, there's always the because in there, so
Yes,
it's always
that could
the
could
grade.
be. But it sounds like, unbeknownst to me, what Jen's saying, you could say then, okay, I'm abandoning the hospice modality and I want the treatment, so. Yeah. Contact your hospice care team about these listed services, or you may end up paying. So I think having that call happen, that it's documented, you let them know, is gonna be very important. I apologize, I got kind of into the weeds on billing and how that works, but is everyone kind of keeping track of it?
We like you getting in the weeds,
Okay.
is that we understand.
Billing
Okay.
is weedy.
Yeah,
Yeah.
say it. Okay. So when we're talking about how hospice is covered, we're always now throwing in the Washington Long-Term Care Trust Act, also known as WACARES. I think I have the flyers on the table. I bring this in because we at the county are a designated education and outreach office for this new program, but it's not relevant to anyone no longer working. So please keep that in mind. We want to make sure no one gets scammed. It's funny, we had a statewide roundtable call from the frontline people like myself about this program. And I brought up to them, I said, you know, we need to start making sure every talk we give to older adults, we're reminding them that this is not something they're involved in. And they were kind of surprised by that. And then lo and behold, I brought up that at least 2 seniors have reported scam calls about this, and then someone from Bellingham on the call said, yeah, it's happened to my seniors too, someone from Spokane. So sure enough, the scammers are out there trying to convince people that are not eligible for this program that they can be if they buy into it somehow. So this is a payroll deduction. I'm getting it out of my payroll, Jen, Melissa are, since July 1. It's 58 cents of every $100. It's going to fund long-term care services for us several years down the road if we pay into it for long enough. It's only for active workers who are getting earned income from an employer. So everybody else can ignore it, and please do. Please let your friends know, because these scam calls are basically saying, oh, you know, give me your social security number, we'll do a deduction from your social security check for this program, or give me your bank account number, we'll draw the, you know, blah, blah, blah. So this is only for active workers, and it's not even gonna start till at least 2026 for the first group of workers. So you can ignore this, it's not gonna help you in any way. What legal documents should you have in place for palliative and or hospice care? So this is kind of leading us from where we were about decision-making, how you decide if you're on hospice or you're off hospice, what view the client had about all this. So these are the basics you definitely want to have and think about. Number one, being a durable financial and healthcare power of attorney form, which needs to be signed and notarized before care is needed. So for those of you providing care to family members, you want to make sure now is the time to get these documents set up. So the financial power of attorney is basically assigning you power as decision maker to make changes, add, subtract to investment accounts, bank accounts, withdraw money as needed, pay bills. Healthcare is for you to make these decisions with regards to how the healthcare for your loved one is going to proceed. So they're basically granting you the power to be the decision maker. These forms need to be signed while the person is known to be of sound mind and able to understand the document. So there's a notary that's gonna have to notarize these forms, and typically the notary is gonna ask the person, do you understand what you're signing and what it's all about? You know, so that's where it's gonna come down. Advanced directive for healthcare, also known as a living will, signed and notarized or witnessed. So this is where we talked about what does that person want for their end of life situation. Do they want artificial hydration, nutrition? What music do they want playing in the room? Do they want to die at home? Is that an adamant thing that they want? Do they want certain fragrances in the room? Do they want certain foods to be provided to them? So this is all a script, that the script that's provided by this person long before they're terminally ill or unconscious, where the script is how you as a decision maker follow these decisions for them when they're no longer able to voice those decisions themselves. Any questions on how these work? Kind of the basics of them. And then we mentioned the PULSE form, and maybe Jen can chime in on this too, because I don't know in practice how some of these things happen, but a PULSE form is the physician order for life-sustaining treatment form, also known as the do not resuscitate form, signed by the physician with you, typically in the office with the physician, going over this, where you're saying, okay, if I'm in a situation where my life is threatened by a cardiac arrest or something like that, typically when I'm already in a terminal condition, then what do I want to have happen in terms of emergency services responding? So maybe you can chime in, Jen, if you're willing. So people often have these forms at their home.
Yep.
And what's your guys' obligation on this, or what's your script you follow?
So this, it's a bright green form. Generally, people are told to put them on the side of their fridge or the back of the bedroom door, and we look in those locations for them. And there's a couple of parts to it. So there's a part A, which is strictly, do you want to be resuscitated or not if your heart stops, regardless of anything else? If your heart stops, do you want us to start CPR and try and resuscitate you? That's a yes or a no question.
Okay.
And what also is important to know, and I don't know if you know this, Matt, but in long-term care facilities, so assisted living, skilled nursing, even adult family homes, I believe, CNAs, their scope of practice doesn't allow them to go beyond Part A. So in a care facility, they can only look at a pulse and say CPR, yes or no. Part B goes on to say, how do I want treatment if I'm very ill, right? Do I want to be transported and have everything done? So like if, you know, especially in the case of your mom, congestive heart failure, if she's in respiratory distress, and it's likely that that may lead to respiratory arrest, her dying, what kind of treatment does she want? Does she want us to put a tube down her throat and breathe for her? That's spelled out in that part A. Or does she want like maybe antibiotics for an infection, but would not want a breathing tube, right? Which is more invasive. Or does she strictly want comfort measures only? Okay, and that's a really important thing to understand from that part B, but also that CNAs in a care facility can't
They don't know
interpret that part
that,
B.
yeah.
So they'll call us.
Okay.
A lot of our providers don't even know that.
Oh, okay.
So, you know,
Gotcha.
and with that comfort measures only, oftentimes it's that they don't even want to be transported to the hospital.
Okay.
So it's kind of, it's a nuanced document. I think a lot of people don't realize that.
Definitely, yeah.
So we have one of those on Mom's fridge.
Okay.
But I don't think there's any place on there where her doctor signed it.
Oh, there should have been.
Somebody had to have
Yeah,
signed it.
if
It
it's a
could have been a
true-
doctor in a hospital.
If it's a true post form, it needs
Okay.
a doctor's signature on it, yeah.
Yeah,
I mean, they did that.
Yeah.
And that's, again, it's
I'll have to look.
different from the living will.
Because it is green.
yeah,
Yeah.
it's a bright green.
And if
Yeah.
they do not resuscitate.
Yeah.
Theoretically, like if she is transported, it technically should go with her. You know, it's a document that everybody on the health team should be respecting and be aware of.
Well, we have it on file at Tacoma General because that's where she's been taken in the past, so they have it in their
Okay,
system.
Okay, good.
but definitely,
Probably
yeah,
take it.
yeah, there's-
Or a copy. Theoretically, it's supposed to be the original, but we'll take copies.
yeah, this is really good information, thanks, Jenny, because this is really good guidance, so, and that's the one where you really need the doctor involvement. I don't even think you can get the form unless you're at the doctor's office and they go through it with you and kind of so you understand what all obligations are there and what is listed there. Different than the financial and healthcare power of attorney, and even different from the living will. That's just the dialogue you're having with the family member, getting that notarized so they understand it. The post form is actually a medical directive from the doctor in conversation with the client. Okay. Then, of course, you want the last will and testament set up, signed, notarized, witnessed ahead of time. And you're gonna need death certificates, that's after the death, of course. This last bullet point, very important, and Jen brought this up too, about where these forms are, they need to be visible and available. Make sure you and other trusted family members and professionals, including attorneys, physicians, have copies of these forms. Keep the originals in a known secure place. I hear some people just take photos of them on their phone. I don't know if that's legit, I don't know if you guys have an understanding on that. I used to keep a folder with me for my mom and dad, and I would actually take that everywhere I would go with the documents. When I was driving, wherever I'd be traveling. And they're only specific to the state of Washington. So, if you've certainly recently arrived here, or you're leaving for another state, you have to get these documents updated in that other state because they're only state by state. Along with that, Social Security does not recognize these documents, nor does Medicare. Your doctor's office will, facilities will, hospitals will, but they won't in terms of questions you might have to ask. You typically have to be the payee for that person with Social Security in order for Social Security to talk with you about their Social Security and Medicare benefits, okay? But for everything else in the state of Washington, these should be on, okay?
You're not saying you carry the UANs around, you're saying you kept a printed copy in,
Exactly, yeah, I would keep the copies with me when I was traveling, we had the originals at home. And typically, like you're describing, once you get them into the hospital system from the doctor's office, they should cross over, and I know, Melissa, we worked on this years ago, do things cross over between multi-care and Franciscan in an emergency situation?
Yeah, I mean, when they go in Epic, they are able to see,
Okay,
different hospital visits. I don't know about documents per
documents,
se.
okay,
Yeah.
the medical stuff's in there, okay,
Um,
okay,
Yeah, I would, if, I don't know, my loved one went to a certain hospital that the primary care physician isn't a part of or whatever, I would want to document
yeah,
that hospital system just to guarantee that.
exactly, because the history of where they go, it depends, there's diverse statuses and stuff where a hospital even close by might be the one that you can go to, might have to go to one in a different network. I mean, they're multi-care and Franciscan are the two divided hospitals, but I think if you jump into South King County, then you run into like Virginia Mason, which I think is Franciscan affiliated. I don't know if Valley Medical Auburn, I don't know who they're affiliated with.
Which is UW,
Does it?
Valley's UW.
Oh, is it? Okay.
And I think too, like the PULST is the physician's order for life-sustaining treatment. So when the PULST comes into place is when things are, it's an emergency situation and there's oftentimes emotions, there can be conflict among family members.
yeah.
You know, it's not the time to be, you know, for a physician in an emergency department to be trying to get into another health systems. You know, it's
Yeah.
so much easier to just have the
Have the
document right
document,
there that has the person's wishes laid out.
Absolutely.
Like, then it just saves everybody's stress and time and
Right
this
there.
is the guide right here. Let's follow this.
Exactly, and that's, like I said, I used to actually carry copies with me when I would go out and about. At the very least, I knew if I was close by to home, exactly where they were at home, if I needed to get them. So, useful to have that, and so, yeah, you wanna make sure you know where they are, a trusted family member or friend knows where they are. That some professional that might be involved with family, knows where they are, the originals are kept in a safe place, all that stuff. And they will be honored, I've never had an issue with that. When I was handling things for my mom, my dad, my uncle, my mom and dad, we shared the same last name, my uncle, we had different last names. Once the documents were there, they were just calling me, what do we need to do with your uncle's cancer treatment? What do we need to do with your mom's congestive heart failure and stuff like that? So once they're there, you're the guy and you're handling it. But it's useful to have those last wishes in place because there were some differences among family members about the hospice care going on hospice so I actually had to have the hospice nurse kind of educate family members of why mom and dad chose what they chose. There were questions about, and we didn't talk about burial plans, but there were questions about cremation plan versus body burial and stuff like that. So it's good that if there are involved family members, sons, daughters, siblings, whoever might be chiming in, that everybody's aware of what last wishes the person is putting down, so there's not arguments about it later. And that's the value of having it written down on paper. Okay, and then the resources at the end here, that's our office there, 798-4600. We cover all of Pierce County for any question you might have on older adult services, disabled adult services. We're county designated aging and disabilities resource center. So that's why I mentioned things like our family caregiver support program. We also have other different types of caregiver programs available. We're doing energy assistance this time of year for folks outside the city of Tacoma. We have home repair programs, all kinds of different things. So please call us with any questions you might have about older adult services or disabled adult services. The Washington State Insurance Commissioner link, I put that on there because they have a lot of information on there about different Medicare plans and things this time of year, and how the Medicare benefit works. Columbia Legal Services, Washington Law Help, I put this on there because when I was talking about the forms like financial and healthcare power of attorney and living will, they have forms that are legal on that homepage that you can print out and actually use for your own uses. So you don't necessarily have to go through the legal planning project to get those set up. You can read through those documents and fill them out yourself with all the relevant information, have them notarized, and then they're legal documents at that point. Dementia Legal Planning Project, we talked about that. If you don't want to do those forms yourself, you want to consult with a legal person, then make sure you talk to them. Walk cares, we talked about that, kind of ruled that out as a need for this population. The Medicare phone number. And then we're always reminding people this time of year about covered vaccinations on Medicare and most health plans. COVID-19 current new boosters are out since October 1st. They've added this third possibility. You can choose Novavax in addition to Pfizer and Moderna. A lot of people were waiting on the Novavax because it has the old flu virus type of technology where it's a adjuvanted COVID virus that's used rather than the mRNA technology. My wife got the Novavax shot last week at Rite Aid. I'm gonna get mine tomorrow. She didn't have any side effects from getting the shot, so that was good. And then free home testing kits available at local libraries. You can also put this into your browser, this web address, and you can order 4 free tests for your household for COVID. You'll get them in about a week. I ordered those a few weeks ago. I got 4 of them. So we always remind people with COVID right now, you get the vaccination. We're hopeful, keeping you from getting too sick. If you do get sick, talk to your doctor. Make sure you're testing at home. The doctors can order oral medication to treat symptoms for COVID. There's a medication called Paxlovid. Plus, when my wife was sick last winter, they prescribed her a medication for her cough, it really suppressed her cough, let her sleep. So we're always reminding people about COVID, still a threat, not like it used to be, but it's still a threat, it's still out there, so. Okay, so we covered a lot of information in a short period of time, so any other questions, comments, stories? Yes, ma'am.
Are a lot of the things similar if you are eligible for Medicaid, the same as Medicare, or?
Great question. So, Medicaid generally is actually more expansive on coverage than Medicare in terms of some of the waivered services you can get on certain programs. So typically a person on Medicaid would even have more expansive coverage in terms of probably nothing to pay out of pocket. And they might be able to get some things approved for medical equipment and things that Medicare would pay on a percentage basis. There's Medicaid eligibility just based on income and assets for folks on Medicare, but then we have caregiver programs that if people qualify, they'll actually be able to get Medicaid even with higher incomes than typical Medicaid is. So this is another reason I would want you to call if there's any caregiver programs or stuff you're looking into for a family member. We have other programs in addition to that family caregiver program that are under the Medicaid umbrella.
So do you just go to Medicaid? Is there a link or something with?
I would have you call us because there's different programs, different ways you get eligible, and it can get really confusing really fast. So
Okay,
we definitely give us a call. We're lucky in the state of Washington that they've added Medicaid programs for caregiver help that are higher income and asset eligibility than the federal standard, in some cases much higher. So we can offer people some caregiver support, especially in these hospice situations that other states aren't able to offer. So this would definitely be something we would want you to call. We have a lot of clientele on hospice and palliative care who call because the family members providing support and they need some help, or it's an adult child providing support, they need a caregiver to come into the home. So we have those opportunities available. We'd love to have you call some of them down.
okay, thank you.
Okay. Well, great. Thanks for being here. Great questions. Thanks to Jen for filling in a lot of gaps there. It's a lot to think about and a lot to handle. Please have a dialogue with your doctor about it. Please use the Medicare booklet as a guide. Use the PowerPoint as a guide. And understand that the programs are there to provide support to the person who's ill, whether it's palliative or hospice care. And nothing is definitive and nothing locks you in. Like Jen said, I was surprised to hear that you can basically end it at any time and seek another treatment modality and then get started again. So try to dispel that myth there, because I think a lot of people avoid the hospice care, which really can be a help in providing comfort and even extending the life of the person who's ill, because you're no longer trying to run them back and forth to doctor's offices and emergency rooms and all these treatments. You're basically providing the comfort, hopefully at home, where they're most happy and most able to relax. Okay, thanks for coming out, appreciate it.
Thank you.
All right, again, thanks. Have everybody have a great weekend and a